Okay, I'm sorry for this last minute. I will enhance my speed. I'm very glad to speak here about this topic coming off psychiatric drugs, as I'm working as this topic since more than 3 decades meanwhile, and from my own experience and from all the experience in the 30 years of being active in this field, I know it's for many people, or for most people who take the drugs, it is the most important issue all the time. When they take drugs, how can they get off? Because they are told if they withdraw, the relapse will come at once. I will give you now a lot of quotes and information, and you do not have to take any notes. You can download the whole file from this internet address, peterlehmann.com/Cork, so you can concentrate. I was just in. There are many reasons to come off psychiatric drugs. In general, people are told it's a kind of symptom of their non-treated illness that they want to come off, and it's very irresponsible. Of course, it's a people's decision, but of course, very often for doctors, for relatives, for the people themselves, it's a very rational decision. You know, there are a lot of chronic or maybe deadly ending diseases combined with psychiatric drugs, and when you realize the early warning signs from these diseases, you simply have to withdraw, and you have to be very careful. For example, when a so-called deficit syndrome is coming, it's also called neuroleptic hepatic syndrome, or so-called syndrome of the broken wing. That means all the energy, the life energy is lost. It can be an irreversible damage. Then, of course, when you realize the first signs, it's time to come off. There are more heavy diseases like suicidality. You know, neuroleptics have an intrinsic effect to produce suicidality. In up to 2/3 of all treated persons, depression up to suicidality can arise. And meanwhile, it's the most often happening death case of people with a diagnosis of schizophrenia or psychosis, that they kill themselves as a result of the effect of the neuroleptic drugs. It's not a side effect, it's more or less the main effect combined with Parkinsonoid, which can be produced. States of delirium can develop as a result of neuroleptics. I focus mainly on neuroleptics. Breast cancer can develop. There have been studies by Halbreich and colleagues in the American Journal of Psychiatry that in women who are treated with psychiatric drugs, breast cancer happens 10 times more often than like in a general society. And there are, of course, early warning signs like the raised prolactin level. Diabetes can happen, can develop as a chronic disease, and of course there are early warning signs. Obesity, malign hypothermia, malign neuroleptic syndrome, agranulocytosis, metabolic syndrome. All these diseases can end deadly, and when there are early warning signs, it's really time to come off. And it's also important to know all these warning signs to act appropriate. In general, people are not informed about these consequences. They are not informed about the warning signs, and so they are given the drugs, but without any information about the risks. There have been research about information by psychiatrists themselves. It's published, and they themselves say if there's no information when we start the drug treatment, there's no information in the course of the treatment, and there's no information when the treatment turns into a long-term treatment. So you can see the situation. People are taking the drugs without any form of informed consent. It's a very illegal situation, but so the situation is. And of course, when people want to come off, also then there's no information about withdrawal problems. Pricolachti, who was, I met her when I was member in the Board of Mental Health Europe. This is the European section of the World Federation for Mental Health. She wrote in the preface of my book, which is called Coming Off Psychiatric Drugs, do we not leave our patients alone with their sorrows and problems when they, for whatever reasons, decide by themselves to come off their psychotropic drugs? Where can they find support, understanding, and good examples if they turn away from us, disappointed, or we from them? Of course, her answer was, read Coming Off Psychiatric Drugs. It's in the preface of this book. When you discuss with psychiatrists, there will be a stand-up reflex answer. There have been studies which clearly show that if people do not take the drugs, the relapse will come sooner or later. And these studies have been restudied by Brigitte Woggon, which is a big fan of psychiatric drugs. It's a psychiatrist from a Zurich University Psychiatric Hospital, and she found out that there never was a differentiation made between withdrawal problems and the return of the original psychological problems. And she says, interestingly, in most studies on withdrawal, no position is taken on possible withdrawal symptoms, apparently because the studies are not set up to deal with these findings. In other words, you can forget all these studies. They are unscientific from the beginning because they do not differentiate in any way. From the beginning of the treatment of neuroleptics, it's very well known in psychiatrists that withdrawal can be combined with a lot of problems. For example, Seelbach, psychiatrist from Berlin, said in 1963, after cold turkey withdrawal from a high dose of neuroleptics, which produced extrapyramidal, this movement disorder symptoms, extreme euphoria accompanied by a rapid pulse, we call it shock or retour, can be caused solely by the withdrawal, in contrast to the previous effective indifference. In Germany, I often refer to information in Germany because it's published in German language. I translated it for this presentation. Have been studies in animals, in this case with rabbits, who got a neuroleptic prototype chlorpromazine. Maybe you know it under the market name Largactil or Soracin. They gave rabbits chlorpromazine for 6 months, and then they stopped abruptly and said at a dosage of 30.3 milligram per kilogram weight of the rabbit of chlorpromazine, abrupt withdrawal led to a sudden death within 14 days, probably due to irreversible blocked metabolic processes that stopped functioning, and similar observations in human beings have been published in which death followed a brief stage of cramping. Vegetative withdrawal symptoms may occur, include anoxuria, binging, nausea, vomiting, gastritis, diarrhea, stomach ache, colic, and a lot of other mostly vegetative symptoms. Of course, muscle problems can arise, and a lot of also of central nervous and emotional problems. Not only in neuroleptics, also in antidepressants, withdrawal problems. So Ronald Kuhn, who was one of the pioneers to introduce antidepressants in the market, wrote in 1960, more than half a century ago, withdrawal problems can look really bad under certain circumstances, bringing on severe headaches, profuse sweating, tachycardia, attacks, sometimes also vomiting, all of which disappear within a half hour or resuming the medication. This is a phenomenon that looks very similar to the withdrawal symptoms of toxicomania, which means drug dependence. Deckwitz is not an antipsychiatric activist. It's one of the former presidents of the German Association for Psychiatry and Neurology. He compared the problems in withdrawal of neuroleptics with the withdrawal of alkaloids. Morphine belongs to this substance group, and writes, the reduction or withdrawal from psycholeptics are antidepressants and neuroleptics, leads to considerable withdrawal symptoms that cannot be distinguished from those symptoms occurring with the withdrawal of alkaloids or sleeping pills. It's well known that the withdrawal of sleeping pills can be very heavy and life dangerous. Back. Okay. Psychic symptoms can be tension, restlessness, destructiveness, aggression, irritability, excitability, withdrawal psychosis, delirious states. Reimer, also former president of the German Association of Psychiatrists and Neurologists, writes, the ultimate factor in the delirium syndrome is certain to be the psychoactive pharmaceuticals. On the surface, it appears to compare the withdrawal delirium on the alcoholic. Long-term administration, psychiatrists tested fluphenazine, a neuroleptic, on animals, and gathered their findings when they gave fluphenazine for a longer time. And they say long-term administration of antipsychotic drugs to animals induces supersensitive mesolimbic postsynaptic dopamine receptors. It is possible that a similar process can occur in men. Following a reduction in a dose of antipsychotic medications or the complete discontinuation, mesolimbic dopamine receptor supersensitivity could be reflected in rapid relapse of schizophrenic patients, the development of schizophrenic symptoms in patients with no prior history of schizophrenia, or in a necessity for ever-increasing doses of long-active depot fluphenazine to maintain a remission. Guiginard and colleagues from the University Clinic in Montreal, they found symptoms of supersensitivity psychosis among about 30% of people taking neuroleptics, even if they do not withdraw. And they made a lot of studies about a rebound and supersensitivity psychosis, and they suggested that dopaminergic supersensitivity also occurs in the mesolimbic region after chronic neuroleptic exposure, resulting in a development of a supersensitivity psychosis. An implication of neuroleptic-induced mesolimbic supersensitivity is that the tendency towards psychotic relapse in such patients is determined by more than just the normal cause of the illness. That means simply by the drug itself. Tornatore and colleagues published a book about emotional or psychic reactions to psychotropic medication, and they published in 1987, there's a worsening of the psychosis as a result of the treatment, like delusions, hallucinations, suspiciousness induced by long-term use of neuroleptic drugs. Typically, those who develop supersensitivity psychosis respond well initially to low or moderate doses of antipsychotics. but with the time seem to require larger doses after each relapse and ultimately megadoses to control symptoms. And in a German edition of the book, they added, thus, a tolerance to the antipsychotic effect seems to develop. It's very important to understand how such a tolerance is built and that is existing at all, because when you discuss with psychiatrists, they all the time deny that this tolerance to antidepressants or to neuroleptics. They will say, oh, it doesn't make addictive. They change from addiction to, from dependency to addiction. Of course, whoever is addictive to get haloperidol, I never found somebody. But if there is a tolerance, and development could come like when in some decades ago in benzodiazepines, there also was some dependency denied, and when the judges made decisions that the producers or the doctors gave benzodiazepines without informing beforehand about the risk of dependency, they had to pay a lot of money for the compensation of the people who got dependent and damaged very much. In general, when people withdraw and experience withdrawal problems, it is taken as a relapse, and they have to take drugs again or even more drugs than before. Cole and Lawrence, they say when a patient develops apparently new psychiatric symptoms after a psychotropic medication is stopped, a differential diagnosis must be made. The symptoms may represent one or a combination of the following: recurrence or rebound of the underlying illness, psychological or physiological withdrawal reactions, or previously unnoticed or delayed drug side effects. In general, such a differentiation diagnosis will not be made. To differentiate the so-called true relapse, that the original problems return, or from the withdrawal symptoms, there is some information from Lacossiere and colleagues from Topeka, Kansas. They say that withdrawal problems occur in about 75% of all people who withdraw neuroleptics, but it depends how closely the subjects are observed and how well documented the psychological condition of the subjects before is documented. Medical withdrawal problems, they say, tend to occur earlier after drug withdrawal than schizophrenic exacerbation, so they call it. They may be accompanied by other medical withdrawal symptoms and usually clear up spontaneously or with supportive treatment within a few days. It's very important for people who come off because they might get very frightened from withdrawal problems, and to understand that there are transient problems and may often disappear by themselves is very relieving. Within biological psychiatry, there is in some members a very high reflective discussion about all the problems combined with withdrawal, even if they do not speak publicly about it. And in the introduction of my book, Coming Off Psychiatric Drugs, I summarized and gathered some of these statements. They speak about a kind of catch-22 situation from a psychiatric perspective. Say there are a lot of problems. Neuroleptics do not heal. There's a belief that patients need permanent treatment. There are a lot of risks of long-term damages, such as tardive dyskinesia. Psychiatrists are reluctant to discontinue neuroleptics for fear of liability. There's a risk of relapse, and more complicated, a lot of people who withdraw do not have a relapse. So they do not really know how to solve the problem theoretically. Carpenter who provided the opportunity of a controlled withdrawal, came to the conclusion also adverse events such as suicide, dissatisfied patients or relatives, loss of job, deteriorating cause, and brain abnormalities can all be observed during drug withdrawal. Each of these is also commonly encountered in the clinical care of medicated patients. It's not special for withdrawal. Helmchen, a psychiatrist from Germany, the one who gave me long-term neuroleptics, he wrote in '83, when looking back on the 25 years since neuroleptics have been made available to us, it can be concluded that indication predictors for a neuroleptic treatment have not been found but are essential. There are clearly patients who remain symptom-free even without neuroleptics, and there are those who continue to display symptoms while gaining no benefit from neuroleptic therapy and who became even more handicapped. Leonhard, psychiatrist of, a psychiatrist from East Berlin, from former GDR. He said in '89, today I unfortunately see very many cases of cycloid psychosis that remain in a toxic pathological state because of constant medication, but which would be perfectly normal without medication. If one could prevent the development of further phases of psychosis with constant medication, then this practice would be justified. But unfortunately, that is not the case. Thus, those patients who would be healthy for extended periods or perhaps forever are held in a permanent toxic state. Bleuler, the son of Eugen Bleuler, 10 minutes, yes, the son of Eugen Bleuler said, and I guess he would, in '72, he would say probably yes, now also, not one single patient who healed or improved lived outside the clinic over years or permanently, has ever taken long-term drugs. The assumption that the majority of improved schizophrenics would stay improved on the long term only under the influence of neuroleptic drugs is an error. First of all, it is an error to assume that announcing relapses after remissions could be avoided by neuroleptic drugs. There are permanent remissions in great quantities, and there are relapses under the influence of neuroleptics in great quantities. Speaking about preconditions for withdrawal, the ideal preconditions would be adequate speed of reduction, gradual dosage reduction, responsible attitude, supporting surroundings, proper help, supportive self-help group, competent professionals. In reality, nearly none of these factors are present. In UK, in 2005, a study from Mind has been made, a user-led research about withdrawal and about the issues which led to a successful withdrawal. And Jan Walcraft wrote a chapter in this book, Alternatives Beyond Psychiatry, and she said, and she was involved in these studies, and she said 2/3 of those who came off neuroleptics or mood stabilizers did so against their doctor's advice or without telling their doctor. It was found that doctors could not predict which patients would be able to come off successfully. Those who stopped taking psychiatric drugs against their doctor's advice were just as likely to succeed as those who came off with physician agreement. The forms of support found most helpful were support from a counselor, a support group, or a contemporary therapist, peer support, information from the internet or from books, and activities such as relaxation, meditation, and exercise. Doctors were found to be the least helpful group to those who wanted to reduce or come off psychiatric drugs. Yes, I would have been able to tell it beforehand. You will find, meanwhile, a lot of internet information about coming off, and especially on this web address, Peter Lehmann Publishing coming off. I now integrated a link to a new American blog and web address where people are supported online when withdrawal. And there are also email lists about withdrawal from benzodiazepines, antidepressants, SSRIs, and neuroleptics. My time is limited. Plan ahead is very important for people who come off. Anticipation of possible withdrawal problems. They can happen, but they do not have to happen. But to be aware, if they come, not to be frightened is very important. In the middle of the 80s, there was a magazine published by David Richman on a pseudonym Dr. Caligari. He was afraid to give his real name, getting to be safe from his colleagues. He says withdrawal from psychiatric drugs can be a very trying experience. You should know. There are a lot of experiences, meanwhile, to come over emotional problems in withdrawal or without withdrawal, and you can find in this book, Alternatives Beyond Psychiatry, a chapter, what helps me if I go mad, and this also fits for people who have withdrawal problems. Get legal protection is very important. We made the experience that people who make, we call it in Germany a psychiatric will, who made such a statement and reflected what made them crazy, who are the persons who help, what will help, will get less, more crazy again, or come in a context with psychiatry than people making no psychiatric will. And in this book, Alternatives Beyond Psychiatry, there's also a chapter from Laura Siegler from USA about legal protection and advanced directives. And she said it's good to make it, but it's not very safe. And meanwhile, in 2009 in Germany, I guess it's the first country worldwide, advice directives of people with psychiatric diagnosis are protected and have to be respected without any discussion. So the situation can change, and we worked in Germany for many years on this situation. Okay, create a quiet environment. If you come off, it's very important. Get enough exercise, reflect alone in self-help or in psychotherapy. If there are no friends, no self-help groups. But of course, psychotherapy can also be very tricky. There are, these terms like psychoeducation, adherence, or concordance therapy, which always means take the drugs. And a lot of psychotherapists are educated by psychiatrists in their studies and learn a lot of shit all the time. Not here, of course, but outside, outside of Cork. Nutrition is very important. And avoiding drugs or alcohol and things might have an irritating or stimulating effect when you come off. There are a lot of palliative and cleaning methods. For example, detoxification can be very important. In Ireland, there is a National Acupuncture Detoxification Association. I gave here the internet link, and they offer maybe, hopefully, an acupuncture system. It's a kind of electroacupuncture to enhance the speed of the drug metabolism out of the body. Overcoming sleeping disturbance is very important. Very often, sleep disturbances can happen during withdrawal and often announce a so-called relapse. And so there are a lot of a lot of experiences meanwhile to overcome sleeping problems. In the Berlin Runaway House, which is the workers are half former survivors. There's a lot of experience meanwhile dealing with sleeping problems, and they like to go in the evening, in the night, make walks to the field, or may listen to music, and but of course there the stuff the stuff in the night is there are more people working like during the day, because during the nights mostly the problems happen, and the problems do not fit to the schedule plan of the people, and of course this is also a result of the experience people made. When I look at the, for me, most important messages of people who came off successfully, who gave their records in the book Coming Off Psychiatric Drugs, say we are not sentenced by others, muzzled by others, we always have more forces available than we might have thought in dark days. Recognize yourself, become your own therapist, help yourself. As long as you believe the doctor that relapse can happen, then it might work like a self-fulfilling prophecy, and then it comes. Face the problems which brought you into the dependency of drugs. It's not very easy, and especially Regina Bellion is a German survivor who wrote a chapter after the withdrawal, then the problems begin. Says it's very, very important to understand why you came in contact with psychiatry, why you got emotional problems which brought you into psychiatry, and you have to understand and change maybe your life and your attitudes simply to prevent it and have a stronger and a more fulfilling life. If you made such an experience, you have to understand that you might be a kind of vulnerable, and you should be live very careful. And of course, in self-help groups, be also very careful, because which fits for the one is not fits also for the other one. And all guides and all ideas of patient recipes are always very dangerous and should give ideas to be very careful. Political consequences, of course, oppose forced treatment, especially legally protected conditions to long-term treatment, collect and spread information about withdrawal problems, develop services for people to overcome dependence, also safe places for withdrawal, fight for compensation, and develop methods and symptoms which do not focus on the treatment or on the administration of psychiatric drugs at all. Of course, there can be also juridical consequences which could be tried to use at once. I read this paper from Simpson in '77, who says the potential of neuroleptics to produce dyskinesia, a serious complication, is a considerable number of patients, would indicate that attempts should be made to withdraw in every patient. And of course, and so I started with this early warning signs, the risk that damages will develop during the treatment, and when psychiatrists' recklessness give further on neuroleptics, they might be with one step in the prison already. And there is this legal principle of recklessness. You can find it on the internet, and damage which is produced by recklessness is considered by law in the same way like intentionally. So this might be a good possibility to fight psychiatric recklessness. I'm ready now. Thank you very much for your attention. there's some time for question and discussion, and after the next lecture, before the lunch starts, you will find me outside at the table because I brought a lot of books with me, and I want to sell them to you. Okay.
Why don't we take questions now?
Now?
Yeah. We could take questions now.
Yeah.